Thank you so much. I think you really made it real. Real case examples. Now, you obviously are on the top of the field. You know how these tools work.
Yeah.
You know how to get information that is relevant. You may actually spot information that is misinformation.
The solution can't be necessarily 1,000 or 10,000 people waiting at UCSF, at Sloan Kettering, at Dana-Farber for their care. Instead, what I'm thinking, where I'm going now, is what if we, instead of having 10,000 people line up, what if we learned from those best centers, right? The best cancer oncologists, they saw this, they did this. They saw this, they did this. Use that, captured in electronic health records, to train AI. Deliver that AI direct to patients, so they're not waiting for a doc anymore, right? It could be patient-facing decision support tools with the right level of understanding needed, but delivered to doctors too, with order sets, with physician-facing decision support tools. So the phrase I use now for artificial intelligence is scalable privilege. This is scalable privilege. We should be learning from every single case. In fact, that's what we're trying to create at the University of California. I mean, literally, we want to learn from every single patient, and we have these natural experiments across the UC to help us get there. Believe me, I wish the care were delivered exactly the same across the UC health system, but we're not a Kaiser, right? Every doc has their own kind of idea. They were trained differently in every aspect of medicine and surgery even. But can we use that? It's a lot of statistical tools to make that work, right? Propensity score matching and things like that. But can we actually use that to then do comparative effectiveness and then learn and then use that data? It's a weird world for us because we want to do comparative effectiveness studies now. We don't need a PCORI grant to do that. We want to do that because then we'll buy things together, right? Which monoclonal antibody should we do or buy? Well, let's figure that out for ourselves and then put in one purchase order. Which biosimilar should we use? Let's make sure they're working and put in one purchase order. So we're kind of financially incentivized to want to do these kinds of studies with this data to make sure we get some financial benefit to reduce the cost of care.
Regarding transparency of these systems. So it's my understanding that OpenAI hasn't published based on which data these tools are trained.
That's right.
So how do we spot biases? How would you go about that?
Yeah, so first of all, let's take the first part of it in terms of transparency. We don't know what OpenAI has been trained on, but we can hallucinate, we can imagine that it's trained on everything that's openly available on the internet. Now, people think, well, what kind of biomedical knowledge could it know, right? There's not going to be a lot of medical notes that are open and publicly available, but all the PubMed abstracts are available. And because of open access rules now, most of our free text papers, entire papers and figures, are also publicly available, right? So I'm imagining, and given some of the results I've seen, I think it's read the papers, right? It's not just the abstracts here because they're freely available. You can, like anyone in the public can, so can large language models now too. So I think it's going to get there, but are they going to tell us what it's trained on beyond vague phrases like open accessible internet? Probably not. I don't think they're going to give us page by page. We don't know if they've paid to unlock paywalls and things like that, right? They might have, but we don't know. Now, the second aspect, though, is bias, right? We know that word bias, I think, has been used maybe 25 times so far this morning. At the same time, though, it's very hard to understand or even evaluate an algorithm for bias, right? I think if we get to anything by the end of this calendar year, I wish we had a method. It doesn't have to be a computer program, some method to say, this algorithm is biased and this one isn't, right? And right now, we're barely at frameworks to get there. We have many groups working on those frameworks. We have the Coalition for Health AI, or CHAI, working on one. There's a bunch like this now. The National Academy of Medicine has a code of conduct for AI that they're working on. But I think we need to get the framework so we can ourselves evaluate for bias, especially if it drifts in and out of bias. We need a better way to tell if something's biased or not. Because right now, we're all flying blind in that. We sorely need that.
The question I ask myself is from a regulatory perspective. I mean, there's reports out there that ChatGPT aces a lot of medical exams.
Yes, it
in a way.
It does.
At the same time, how should we think about the regulatory system? Is it like how we should regulate a software as a medical device, or is it more like how do we qualify a physician?
Yeah. Okay. So yes. GPT passes the medical boards. Makes me wonder. So what do we do with that, right? So now, when the pass-fail for the medical boards is an arbitrary number, right? We want some number to pass, a good number, and some number are going to fail, right? And that number is set. But what does it mean now that like software can pass? Should we ask every human now to get better than GPT? I actually wonder that. Why would we pass a human that gets worse than a computer program at this point? But yes, it passes the GPT passes the boards. It passes the law bar. My favorite is it passes the sommelier exam, okay? It doesn't know how to taste the wine, but passes the sommelier. Now, again, you can find humans that pass those three. It's very hard to find one human that passes all three of those, actually, especially sommelier pin. It's kind of hard to get. So yeah, it's passing those exams. What does it mean for humans on that? Now, the regulatory burden, right? I showed you an FDA cover. I respect the FDA for doing this. And I think they have a model for embedded software, algorithms that might be in hardware devices or just software tools like sepsis and others. They're going to be regulating that. Something as massive as GPT, I'm not sure how they're going to regulate that. And it doesn't necessarily have to be regulated by the FDA, right? So when a patient Googles medical terms, right, they don't regulate Google, right? When a patient watches Oprah or Dr. Oz to get medical advice, well, the FDA doesn't regulate Dr. Oz and Oprah, right? When a physician reads a textbook to learn medicine, well, the FDA doesn't regulate textbooks either, right? How do physicians regulate each other? Well, we regulate each other, right? We have professional societies, we have the board exams, and so there are self-governance mechanisms in medicine as well. All I'm saying is it doesn't necessarily have to be the FDA for GPT, and there are various incarnations and their uses. It doesn't have to be that way. We'll have to see where it goes.
And coming now back to diagnostics, so how should we as a diagnostic company think about embracing tools like ChatGPT?
Yeah, I think it still comes as a surprise to diagnostic companies that, we're giving your raw results you give to the doctor to the patient, right? And if you think the doctor can't read that, imagine the patient getting that in the Apple Health app. That is, you shouldn't just be imagining that, you should be testing for that, right? The impression, the results, clinical trials, you have to imagine every report that comes out of one of your sophisticated tester devices makes it into the hands of the patient today. That's federal law, right? It's in the app right now. If it's in my chart, it'll be in the Apple Health app if you have a compliant health system. That's the design you should be designing for today. Patients have a right to all of it, and they're going to start using that right. So what does your note look like when it comes off of a sequencer? How understandable is it for a patient? And what should they do with that? That's your immediate design goal, I think.
Yeah, it's almost like a different way to interact with the physician, with the patient, a new interface.
It's a new interface for sure. Should we take questions from the audience?
Are there any questions?
Yeah, I saw a couple hands already.
Hi, Atul, thank you. So I was very intrigued by the ability to experiment within the system,
yeah,
both with and iterate in new applications of AI or also on data, new drugs, etc. So what is the minimum criteria that you establish to actually do these type of experiments in the system?
Yeah, so remember, we're an academic medical center in a massive university, right? So we're not a community hospital setting, though we have community hospitals as part of our 12 and growing centers here. But we're fundamentally a research institution. We have folks who think about AI. We have folks at Berkeley and the medical centers. So first, you have to have folks ready to do R&D. One of the things we knew this day was coming is, so we prepared very much so at UCSF to get our data de-identified, right? When it's de-identified and so de-identified, it's what the IRBs call non-human subjects research. It cannot be re-identified. Then you can really start to work with external companies. Now, we get them to sign what are called HIPAA BAAs, just in case, right? We say you cannot re-identify our folks. You cannot even try to re-identify. The full weight of the UC will come down on you. So we have those rules in place. Right? De-identify doesn't mean open access data. But we've set it up so that we can actually start to explore like crazy. We know we have a little bit of a lead, but we know of peer institutions. NYU Langone has their nodes de-identified. University of Florida, Gainesville, you saw the press release with NVIDIA. They have their nodes de-identified. I know many other places are de-identifying as fast as they can now to try to get to those use cases. And we don't fully know, right? I showed you inbox messaging, but there might be 100 other use cases for GPT LLMs in healthcare. We're just trying to explore as many as we can and then see which, throw them at the wall, see what sticks. But we're a research institution, so we can try to go as fast as we can that way. Safely, responsibly, respectfully, though. I'm going to keep using those phrases, right? We have to engage patients in this. That's why even on my oversight board, I have 2 patient organizations, including cancer care organization. We have every single IRB has patients on them, so we have to make sure that, that we never forget that. Please.
So in today's regulatory framework, it could take 3 to 5 years to develop, validate, and get clearance for a sepsis prediction model, for example.
Yeah.
But the patient-facing LLMs are not regulated.
Imagine that.
So is there a role for a company like ours to invest those 3 to 5 years and millions of dollars to produce sepsis prediction models versus maybe focusing more on the patient-facing LLM?
Absolutely. Great question about the patient-facing side of it, right? Now, I waved a massive hand on that, right? We can build these tools. We can put them in open access. Stanford put it in GitHub so anyone can download that code. I think it's still an exercise to figure out how to get paid for those. There are graveyards of companies that have been patient-facing anything, right? Whether it's patient health records. Wasn't that Google Health like 1.0? I think we're at 4.0 now. I mean, so many, Microsoft had Vault. I mean, we have had many patient-facing tools that people think they can, eventually monetize or get paid for. So that's still a big exercise there in today's healthcare, system. I mean, who would pay for that? But in the meantime, we can go forward and give them away for free. How does the FDA deal with free when nobody's going to make money on this? No one's selling it. Go download. I'm not sure they're used to that framework. We'll see.
Last question.
Great talk. Thank
you.
What are your thoughts about data sharing? Not only between health systems, but there are hundreds of failed or successful pharma trials that bury all the side effect information and efficacy information. So how do we unlock those? Okay,
so data sharing, and I'll explain at the end why we got ours to work. So everyone runs trials, diagnostic companies would sponsor trials, pharma companies run trials, and there have been major efforts that have been stood up and collapsed within pharma. We know that. You have to have the use cases. They've got to be really good use cases. They can't be theoretical ones. Like some unmet need that data, having that data is going to actually add to value. Now, why do we have our data together? Believe me, I did not go way back 8 years ago to say to our healthcare CEOs, I need to write better papers and grants. No. They wouldn't even give me the time of day, right? What we did say is we need to count. We need to know how many of our patients get this and that so we can buy things together, so we can report on quality together, saving time to build those algorithms, those reports, and really do things together to scale, to use our scale. Once you have the data in one place, boy, research AI is already, you got the data already. De-identify and go wild in some ways, safely, responsibly. But that wasn't the reason. AI is not the reason why we're putting data together, right? AI is still generating millions, best case scenario. Our health system is making billions, right? We want that to be not threatened anymore. We want to make sure we can reduce the cost of our care. That helps by putting data together. That's the prime driver. You have to have a monetary business use case to want to put data together. Then once you have it, you can do the research.
Thank you so much. We could go on forever.
We could.
We could.
Thank you so much.
Thank you.